In the world where infertility rates are rising and women are waiting longer to start families, waiting until you fail first before we even get data about your body absolutely does not make sense. We've got to switch from a reactive to a proactive mindset.
The trauma that it takes on women, how they feel about it, it's so hard to watch. You wait until there's been enough losses, but why?
There's a ton of misinformation on the internet, and some of it can be really quite harmful. The piece that's going around right now that I think we should bust, he's out there saying that getting blood drawn during pregnancy is the top cause of miscarriage.
Thank you so much for being here, Dr. Natalie Crawford, with her new book, The Fertility Formula. I am so excited to have you on our show. You know, we became fast friends. We were just talking about this, and there's just something about your energy and just the way you present things that I think women relate to it so well. So,
Sheila, thank you. And thank you for having me here.
of course, your book has really revolutionized the way women look at fertility, infertility, ovarian aging, all the topics that you discuss in the book. So what I kind of want to start with, you built a whole career around fertility, but what's something most women think they understand about fertility that's actually totally wrong? What do you think?
Most women really think that their fertility is just a matter of luck. Either they get pregnant or they don't. When the reality is you can't control everything, but there's a lot that you can control, which does play a role in your ability to get pregnant. Whether that's understanding your body, tracking ovulation, how you time intercourse, but also how you optimize your lifestyle and decrease inflammation. All of those factors play a role in your ability to get pregnant, whether that's with or without fertility treatments. And these are things that women deserve to know.
I couldn't agree more with you. Was there a moment in your training or kind of like part of your earlier career that you realized, hey, women are being failed about how we're talking to them about fertility, infertility, and how did that realization actually shape the way you practice and, ultimately you wrote the book?
One of the central premises of the book, and that I believe, is that you shouldn't have to fail first to get care. And I think it's important for the listener to understand that infertility is a medical definition, and it is defined as when you try to get pregnant for 12 months and do not have success. And classically, physicians are trained to evaluate for infertility only at that time period, meaning if a patient had walked into your office and said, we want to get pregnant, what should we do? You might talk a little about prenatal vitamins or optimizing some things, but you wouldn't be offering fertility testing at that time until they've demonstrated failure. But the root of that question really came from my own experience. I had multiple pregnancy losses when I was in training. We started trying towards the end of my OBGYN residency. And OBGYN residency, as you know, is 4 years, and then reproductive endocrinology fellowship is 3 years. And I had 4 pregnancy losses during this time before I had my 2 kids. Angela, it was very interesting, despite saying these things to patients myself in my training, when I was on the other side of the table, asking questions that got dismissed, being told it was bad luck and there was nothing I could do, was such a disempowering feeling. Thinking, I've got to do something. Am I running too much? What should I be eating? What about this? And everything really got dismissed and pushed to the side. That made me realize how hard it is when we set these fast guidelines and really set this central core belief that I don't think I should be the gatekeeper for somebody getting data about their body. Because that's how I felt when I sat across from my own physicians. Oh, you need to go have a 3rd pregnancy loss before we'll do testing for recurrent pregnancy loss. Talk about, insult to injury. In the same time period, in fellowship, you do a 1.5 years of clinical work and a 1.5 years of research. So to be a fertility doctor, you have to publish papers, you have to defend a thesis with your oral boards. So research is a big part of the puzzle. And most people do an IVF project because it's pretty easy. You can control more variables. And I really wanted to study what we call natural fertility or fecundability, probability of pregnancy per month. Why do some groups of people get pregnant and other people don't? I really had that as an underlying question. I don't think it's just bad luck. There have
Mhm.
to be some factors women just are not aware of. And in this time, I started studying endocrine disrupting chemicals, vitamin levels, looking at the luteal phase, fertility awareness methods, and really saw over and over in the literature, and this is 13 plus years ago, the word inflammation, which was very interesting because at the time, we talked about inflammation on the disease state, right? We said, oh,
Mhm.
endometriosis causes inflammation, so it is bad. We never talked about inflammation predating the disease state. And it planted the seed for me that inflammation starts to occur before we get sick. And all of the literature supports that women who are exposed to higher levels of chronic inflammation from a variety of different places, they have a plethora of issues with fertility, not just difficulty getting pregnant, but that's one, but more irregular cycles, abnormal ovulation and hormone production, and even earlier acceleration of the loss of eggs in the vault, so going into menopause earlier. And that became eye-opening and alarming, and a big reason why I'm so passionate about bringing this information about what you can do before you even set foot in the clinic or what you can control on your own, because there are factors that play a role and they're not all easy to control, but they're not all hard either. But we have to know about them if we want to do anything
You
about
wanna
them.
Yeah, absolutely. You have to, it's the root cause analysis, right?
Yes.
And you're not wrong when you say that's what we were trained to do. You wait
Yeah.
until there's been enough losses. Like, but why?
Why?
Why do you, and the trauma that it takes on women and just how they feel about it, it's so hard to watch. When I was practicing both OBGYN, I wouldn't wait till the third loss. After one, that was more than plenty for me.
Oh, same, especially after I went through my own.
Yeah.
But before then, I
Yeah.
was a resident and I followed
The
what I was
rules.
told to do.
Right.
And then being on the other side of the table, realized very quickly, what's the worst case scenario? We do some testing, and if it comes back normal, the patient feels reassured.
Correct.
And if it comes back abnormal, well, now we have an earlier opportunity for intervention. Like, that doesn't seem bad to me.
Right. Absolutely. I couldn't agree with you more. I love that. Tell me about the book, the core message of your book. I love it so much. The fertility formula. What is the one mindset shift you hope a woman reading the book walks away with?
Oh, that you have a lot more control and agency over your health than you've ever been told. Fertility at its core is actually a health marker. We think about fertility being the ability to get pregnant, right? But if we really want to walk it back, we know that women who have infertility have higher rates of chronic disease, specifically things like heart disease, heart attack, stroke, metabolic syndrome, cancer, and earlier death. Really scary statistics. And it's not that infertility causes any of these, it's that the chronic inflammation underlying infertility puts you at risk for these other diseases. And I'd really love for us to also view infertility as a symptom, not just a disease. For many young couples, it's the first time their body's being challenged. It is giving us insight into our cellular health. I find it a very disempowering message to just say that there's nothing you can do or it's all your age, when there are factors that are within your control. You deserve to know them. And to say one more thing, as a woman who's had her own medical problems and walked through the medical side of things as a patient, when you get dismissed, you start to believe the narrative at some point, and then you dismiss yourself and your own symptoms, and you wait until you get really sick to demand answers. And so my big beliefs for the book are multiple. One would be that women start to feel confident in trusting their bodies again and saying, this is how I feel, this is what inflammation is for me, this is what's normal, and this is what's abnormal. And I demand answers for the abnormal. And the other is that I really think that as a field, I love being a fertility doctor. And I love my colleagues, but we're doing it wrong. In the world where infertility rates are rising and women are waiting longer to start families, waiting until you fail first before we even get data about your body absolutely does not make sense. We've got to switch from a reactive to a proactive mindset and start talking about how do you optimize your health with lifestyle? How do you track ovulation? And let's get fertility testing before you start trying to conceive, Because if we do that and find a problem, like we said earlier, then we can intervene sooner. Time at its essence is your most valuable commodity, and we need to leverage it and use it really wisely.
Yeah. Talk to me about women in their 30s, right? There's so much, and we're finding out that infertility is becoming more common in the younger population versus the older population. What do you think is driving all of that right now?
It's the world around us. We know directly that the world is becoming a more toxic and inflammatory place. And unless we actively make choices to decrease this inflammation, our body will suffer the consequences, including our fertility, because it is so sensitive to the world around us, right? The ability for a woman to carry a child is a huge energy expenditure. Your brain and ovaries have to be coordinating really well. And as we see, just living your normal life, accepting how the world is, for most people will lead them to a state of health that's not suitable for optimal fertility. And the way I like to think about it for my patients is to say, inflammation is actually normal, right? Acute inflammation is a normal part of your immune system in response to something important for healing. I love to use the example, if you get a cut on your hand, you have acute inflammation and it heals the cut. And acute inflammation is really important for ovulation, in fact. Your egg grows inside a fluid-filled structure called a follicle. As it gets to ovulation, the follicle ruptures and the egg is released, and then the follicle reforms and becomes the corpus luteum that makes progesterone. Well, if you take anti-inflammatory medication, the follicle won't rupture and release the egg. It'll actually block that part of the process. Sometimes patients will just ask, well, if inflammation's bad, can I just take an anti-inflammatory medication? And the answer is no, but we want to get rid of all this excess inflammation, what we call the chronic inflammation, when that part of our immune system is constantly activated from the world around us. And this is often from the foods we eat, the toxins we're exposed to, and then foundationally, how we structure our day, whether we realize it or not, how much sleep we get, the stress we're exposed to, the type of exercise we do or we don't do. So I imagine a scale of inflammation called the inflammatory burden that we have every day. And our goal is to keep it as low as possible so that you have the resilience to have your normal immune system function, because you will encounter one-offs every single day. It's not about being perfect in every moment. It's really about cultivating a mindset where you're making active choices from a place of knowledge, because everything either raises or lowers that inflammatory burden. There's truly nothing neutral in this world, right?
Absolutely.
And so we really, it doesn't mean you have to be perfect all the time, but if you don't get as much sleep, well then knowing that, maybe you need to make better food choices that day to help decrease inflammation. So it's about allowing yourself the grace to develop and cultivate that resilience.
Yeah. And to have a kind of a checks and balances system set in place where you understand what's happening in your body, like you said before, and making these adjustments on a daily basis. It's not about perfection.
100%.
It's about little changes over time, which will add up in a positive manner.
Exactly. The sum of these decisions can make a hugely significant impact on your health, your hormones, your fertility if you're trying to get pregnant, but even zooming out from that, the lifespan and the function of your ovaries, how you experience perimenopause and menopause, and your longevity. So it's vastly important for women to hear this, whether or not they're trying to get pregnant at this moment.
Right. So let's talk about hormones and like whole body health in terms of fertility is often reduced to ovaries and our eggs. But we know it's such a bigger conversation than that. How do you kind of delved into it a little bit, but I want a little more about the metabolic health, the stress, the lifestyle changes. How do we explain this to women? Because it's such a foreign concept that now we know this has been underlying for a long time, but it's not how it's presented.
You're correct. The ovary does much more than just make eggs. The hormones that the ovary does make are vastly important to your whole body health, both now and in the future. And the ovary makes hormones like estrogen, progesterone, testosterone, and continues to function even after menopause, right? Menopause is when we no longer will make eggs and ovulate, but the ovary still has a purpose and a function. Here is my big description when we think about metabolic health in the ovary directly, because having insulin resistance is one of the top drivers of chronic inflammation.
Mhm.
But most patients who sit across from me will say, oh, I don't have diabetes. Like, this doesn't apply to me. But we know that insulin resistance is a major player in this country and specifically for fertility. Women who do not have PCOS or known insulin resistance, when we look at who has had failed IVF cycles or who has had recurrent pregnancy loss, significantly higher proportion of patients who have insulin resistance fall into that poor outcome category.
Mhm.
So seemingly, quote, healthy individuals. And then to double down on that, lab tests only reflect population-based norms. So when we think about a fasting insulin, which is one great way to check for insulin resistance, as a population gets less healthy, the normal reference range will also reflect poorer health.
Mhm.
So I like to see a fasting insulin level much lower than what my reference range might be at the lab that I use. Insulin's a hard idea for a lot of people to understand, though, but I think it's crucial for us to understand it if we want to then jump into all the lifestyle changes. Because once we understand how they're tied, women are smart and brilliant.
Mhm.
Once we give them that benefit of the doubt, then they can easily make changes. So here's my 1-minute explanation of insulin resistance. Let's imagine glucose is the fuel for the cell. So every single cell in your body needs glucose for energy. The food you eat gets broken down into glucose. In the perfect world, you eat food, glucose is in your blood, your pancreas releases a hormone called insulin. Insulin, I like to imagine as the salesman knocking on the door of the cell opens the door, and glucose goes in. So when the system is functioning, they raise and fall together. Glucose goes up, insulin goes up, they both go down. Insulin resistance happens because the cell is exposed to more glucose than it should. So the type of foods you eat, they might cause a higher glucose burden that's called a high glycemic index. Eating more frequently can raise your blood glucose, but even chronic stress, not getting enough sleep. So you have higher glucose in your blood, and the pancreas does what it's supposed to do, and it releases more insulin. And just like a human would start to ignore a salesman who's coming to knock on their door every day, right? Because that's what I would do. I'd look out the window. Why are you coming? That's what your cell does. It says, I'm really sick of seeing insulin. It's around all the time. But your cell's really hungry for glucose. So then your liver starts to break down its stored glucose, and you get even more glucose in your blood. And then the pancreas releases even more insulin. And now the salesman is banging on the door, and you finally go answer it because you want him to go away. And then glucose can go in the cell. And this is what insulin resistance is. Your cell will respond, but it takes insulin at such a high level that the salesman is banging on the door for the door to open. And that's not a benign process because insulin, as we know, is a growth hormone. It is directly causing you to distribute that visceral fat, the abdominal fat that everybody hates. It is causing high levels of inflammation. It's feeding back to the brain that this is not an optimal metabolic environment. So the brain is going to start to send off hormones wrong. I like to think of that as static interference on the radio. And then to be really specific, high insulin changes at the ovarian level how the ovary functions. So it changes the type of hormones that it makes. It responds wrong, even if you got a correct signal. And it changes the quality of the eggs or their function. It causes more abnormally shaped mitochondria, changes the chromosome normalcy inside the eggs. So we see that insulin resistance and chronic inflammation interferes with brain-ovary communication, hormone production, and egg quality. And then to double down even more, the number of eggs that you have. So it's hitting so many different markers. And that's why we can't just say, oh, I don't have diabetes, this doesn't apply to me. It is very rare that I find a patient whose fasting insulin is in the normal range, who's sitting across from me in my clinic. It's not never, but almost everybody has room for improvement on that scale.
And talk to me about how do you view the new GLP-1 medications, which we know they're not new, but again, they're being used in newer ways now. And how does that play into, since we're talking insulin resistance and metabolic health, how do you work that into infertility patients' workup?
Great question. The first thing I always want to say and start with is those 5 principles we talked about earlier: sleep, stress, exercise, food, and toxins. They have to be mastered first, but medication options can be advantageous. So traditional ones, metformin is one option.
Mhm.
Another is inositol, which is an over-the-counter supplement. And both of these improve sensitivity to insulin, helping the cells respond at a lower insulin level. GLP-1s are very powerful.
Mhm.
As we know, they are historically a diabetic medication that is changing how your body processes both the level of inflammation that it has and hugely powerful for insulin resistance. The hard thing for us in fertility right now is that there's a recommendation for 2 months off of a GLP-1 before conception due to fear of fetal side effects.
Mhm.
And we take that really seriously because there have been times in medical history where medications have been introduced too early and pregnant women have been exposed to them during critical time periods of development. And we've seen fetal birth effects, like thalidomide's a great example. So we want to be very mindful before we feel comfortable with something being on a medication right up until conception. So that makes it a little bit difficult for us if you say, I'm trying to get pregnant and I want to be on a GLP-1. With that being said, very impactful for weight loss. We know that just simply being overweight, fat cells are inflammatory. They also make estrogen, interfering with this process. For PCOS, which at its hallmark is a metabolic disease where insulin resistance predominates. So very helpful for PCOS. Women will restore ovulation. And it's really this group that got that target of Ozempic babies, right? Because a woman who would not have regular cycles, long-standing infertility, would go on a GLP-1, insulin resistance would improve, ovulation would restore, and then they would get pregnant.
Right.
But where I think the most exciting data comes from is this chronic inflammatory disease group that is often hard to diagnose. This underlies a lot of unexplained infertility, unexplained pregnancy loss. Think endometriosis, autoimmune disease. Because of the ability of these medications to lower that baseline inflammation, which is so hard to do, right? When I talk about lifestyle modifications with these patients, I always say we're just trying to not add to the scale because if you have endometriosis, you have a level of inflammation in your body. I have yet to this time had a medication I could offer you and continue to ovulate while I lower your inflammatory burden outside now a GLP-1. I consider them a purposeful pause in fertility treatment. So you might go on the medication because we're trying to optimize your metabolic health and environment. And then we may do an embryo transfer or an IVF cycle or try to get you pregnant. I also think it's important to say we don't have known reports of fetal birth effects from them, but due to an abundance of caution, we still do recommend that 2-month gap.
I like that. Okay. We have been, we've gone from having this silence around fertility to now an overwhelming amount of information online. I love social media, but there's pros and cons to it, right? Do you think that it's helping or hurting women? What's the one narrative that you've noticed on social media around fertility culture that you think is actually hurting more than helping?
I started social media over 10 years ago.
Okay.
So I remember the days where people would have faceless and nameless accounts trying to share their fertility journey. It was still something talked about in secret and shame and stigma. And it was very hard for women to get accurate, reliable health information. I think it's incredible to live in the era where women feel confident enough sharing their story in real time. And to think of some of the celebrities or public figures who have shared their, gestational surrogacy journey, who have shared egg donation, going through IVF, miscarriages. That has such a huge power to make other women not feel alone and to feel comfortable asking questions. That leads me to believe, on the whole, social media has changed the game. I sit across from women who are so much better educated than I did a decade ago. But you're right, there's a ton of misinformation on the internet, and some of it can be really quite harmful. The piece that's going around right now that I think we should bust, I don't even know if you've heard this one, but there is an account with a very huge millions and millions of followers. And he's not a medical provider, but the spirits tell him medical information. And he's out there saying that getting blood drawn during pregnancy is the top cause of miscarriage.
Okay.
I don't know if you've heard that one.
I have not.
So he
Quite
is
interesting.
recommending that people decline blood draws in pregnancy.
Wow.
Okay. So this is very important for us to say, getting your blood drawn in pregnancy is not a stressful state. This is not going to cause you to have a miscarriage. And it's very important for us to be able to monitor you and your baby throughout a pregnancy. But it shows how a large account spreading something that has no basis in reality can be really hurtful. And I think the second narrative we're seeing a lot right now is birth control. I know you've seen this one
I've
too.
seen this one. Yep.
Right? The decision to use a hormonal contraceptive should be yours and yours alone. You definitely need a good discussion with your doctor about pros and cons, risks and benefits. Any medication you take, contraception included, has side effects or risks, right? Nothing is net neutral in this world. But it can have immense benefits both for medical treatment and also for prevention of pregnancy. But birth control does not cause infertility. Doesn't cause you to run out of eggs any faster, doesn't make it harder for you to ovulate later. Yes, we have a culture of women, not a culture, but a medical culture where women were not explained what was going on with their body. They were given the pill specifically as a medical treatment without any nuance to what was going on, information about what would happen when they stopped it, or how they could improve their health in the interim. And that's completely wrong. But that doesn't mean that birth control is inherently harmful. And I do think it's important to say it does not been proven to cause infertility. We've had very large studies with 15,000 plus patients in them to say that confidently.
Right. No, absolutely. When I see patients, they always ask me that question. Now the younger patients too, they're afraid because of this narrative of taking care of themselves with contraception, thinking that they may have infertility down the road and have to deal with that.
They don't want to do something wrong, which is really commendable that they're even smart enough to ask the question.
Absolutely.
But they have fear because of what they've seen on social media, and that is sad.
Right. And, and that's kind of why I love having these conversations, is to really get it from the experts, right? Not from influencer-based accounts, but really from the experts who are in it, doing it every day. That's where you're going to get the right information.
I love that. I tell patients all the time, my job is to help you get pregnant.
Right.
I have no problem being a meanie, meaning if there is something that's going to make that harder for you to get pregnant, I'm going to let you know, no matter how much you love it, right? And we actually do this all the time. We talk about drinking alcohol and cannabis and nicotine and things that patients do love, saying, hey, those are harming you. So if birth control was harming across the population, we'd be screaming it from the rooftops.
We'd be the first ones telling you, hey, don't use this. This is not good for you. So how do you educate women about fertility timelines without creating some kind of panic in them? What does an empowered fertility conversation actually look like in your office, someone sitting across from you?
There's this idea that women can't handle hard information. And I push back on that because women can handle any information. And for the majority of women, the unknown is the scariest thing that we can face. This is an important question you're asking because, yes, your fertility does decline with age, both because you have fewer eggs as you get older and because the quality of those eggs, which is a combination of both the normalcy, like are the genetic chromosomes in the right order, and the competency. Can the egg respond to hormones? Can it function? Do the mitochondria, are they healthy? Because all your mitochondria get passed from your eggs to the embryo. So there's this nuance between function, genetics, and the number of eggs you have that inherently does make it harder to get pregnant as you get older. Couple problems here. One is that as a field, we've simplified egg quality to be simply age. As a population, people do tend to get less healthy as they get older. So it's not a false narrative, but it makes you feel like, well, I can't rewind the clock, so there's nothing I can do. And that's not true. Focusing on egg quality, especially as you get older or you have fewer eggs, is inherently really important. Also, most women are not out of eggs at 35.
Right.
I see so many appointments for women thinking, I just had my 35th birthday, so that's it for me. And that's not true. That line exists because it is a good time, I like to say, for a fertility check-in to know what is happening. So I don't push back on the idea that 35 is an important number for women, especially if you still want a family one day and you haven't started or completed that family. It is a good opportunity for us to get an evaluation. But because of the quality, not the quantity of eggs, it is harder to get pregnant at 35 than 30. At age 30, we see about a 20% chance of pregnancy per month. At 35, it's closer to 12%. But then at 38, it's 5% per month. And that's not ever, but per month. Meaning at age 38, it is harder and takes most people longer to get pregnant. That's just important for you to know. Because what if you want 3 or 4 kids? What if you're getting started later? We want to put all of this into a picture. The thing that I dislike the most about the age narrative is that women do think it's correlated with running out of eggs, but also as physicians, many physicians have lost the power to feel confident to order the one test that we know can at least give us an insight into our egg count. This test is called AMH, or anti-Mullerian hormone. AMH is made from the cells that surround all of the eggs. So to put it simply, if you've got more eggs, you're going to have a higher AMH. If you have fewer eggs, you'll have lower. It's not a perfect test. It doesn't mean you'll get pregnant because your AMH is normal. It doesn't mean you can't get pregnant if it's not normal. But it is the one clue we get. Now, ACOG, the American College of OBGYN, says not to check an AMH unless you have infertility. And their rationale is that it's too stressful for a woman to find this out when it's not proven to cause infertility. And I really push back on this because I think that, one, something being too stressful is not a reason for me to do it or not do it. And two, I don't think it's stressful at all if we explain it. Because if you find out you have a low AMH, number one, why is it low? I think it's too simplistic to say a low AMH doesn't impact your fertility, because we know endometriosis can cause a low AMH and impact your fertility. We know that smoking cigarettes can cause a low AMH and also impact your fertility, autoimmune disease, and the list goes on. So if you have a low AMH, number one, why is it low? It gives us an opportunity to do an evaluation. And getting a diagnosis of something like endo or Hashimoto's earlier can totally change the trajectory of your health and your fertility. Number two, it gives you the opportunity to think about your fertility in a more finite way and to say, what will I do with this information? Maybe you're with a partner and you were waiting for the perfect time and you shift your timeline up. You say, gosh, I don't have as many eggs. I will go into menopause earlier. I should shift up when we start our family. Maybe you freeze your eggs. Maybe you freeze embryos. Maybe you work really hard to decrease inflammation because you can't do any of the other things. At the end of the day, fertility will end for us all. Right. And being the one to make that decision to say, hey, I knew my egg count was low. I wasn't in a position where I wanted to do anything about it, but I knew it. That ultimately is more power than later in life just finding out you're out of eggs and having no choice.
Absolutely.
Right? And then to end this is that if your AMH is low, you are on a track to start perimenopause earlier and go into menopause. It gives you the opportunity to start focusing on your health earlier, to understand what symptoms to look for, especially if you're in the category where perimenopause may happen in your 30s. To be clear, perimenopause shouldn't happen in your 30s, right?
Exactly.
If the average age of menopause, 51, 52, perimenopause or those hormonal shifts before, typically we'll say at most 7 to 10 years before then, means that the majority of people should not enter perimenopause until around their mid-40s, right? But if you have a low egg count, you'll go into menopause early, you'll start perimenopause early. And being able to get on top of that sooner, know what to look out for, build your bone, build your muscle, master your nutrition earlier, that's going to change the trajectory of how you age. So again, one single test can change right now how you view conception and how you view aging, yet ACOG tells physicians not to order it.
But I think you nailed it on the head when you said you can't just give a woman a number, a test result, and just let her sit with it. If you explain it, if you take the time to break it down and kind of paint a picture for them, I think that's where it's at. That's where you're going to get your biggest, bang for your buck, whatever you want to call it. But that's what women deserve, is that kind of messaging.
And Gila, I agree. And because so many physicians listen to your podcast, I want to say this. Look, in the same breath, if we take care of women and we say, are you trying to get pregnant? Do you want birth control? The next question should be, do you want kids one day? And should we check your AMH? And if it's scary to you because you don't know how to interpret, you can send to us. We will happily see patients and counsel them on an AMH and talk about their family goals, regardless if they are trying to get pregnant or have infertility. But you being the person to be willing to draw the test, to simply ask the question, there are women's lives that you will change and they will forever be grateful for you. Versus your other option is if they ask, can I get an AMH drawn? And you say no, ACOG recommends against it. And she finds out her egg count is low in a few years when it's too late to do anything, she'll always look back on that moment and feel like you prevented her from getting really vital information for her health.
Absolutely.
So let's all be on the same team of taking care of women together.
Absolutely. And in the best way possible, right? So I'm going to do some rapid fire questions for
Okay.
you. Okay. One fertility myth.
That infertility is all female. It's 50-50 male and female. It's very important that we check the male partner as well.
Okay. One thing women should stop stressing about.
Oh, that's a great one. Stress itself is really harmful. It does cause insulin resistance and causes chronic inflammation. So the idea of stop stressing about being stressed is a really not helpful narrative. What I like to say to that is take the time to arm yourself with information, and then you don't have to stress about it because you know. We'll use toxins. Toxins are actually really impactful to your hormone health. So instead of being, oh my gosh, is there a candle? Is there a this? Take charge of what's in your control. So your home. Look at your kitchen, your bathroom products, the soaps, the laundry detergents, and make very mindful choices to decrease toxin exposure there. And then you don't have to stress when you're on a plane or you're on vacation or you're somewhere where you don't control the environment.
Yeah, I love that. The low tox, we're going to talk about that too. Okay, best age to start thinking about fertility. One sentence.
The moment you're asking the question is the right age to start getting an evaluation done.
Yeah, I love it. That's good. So if a woman is listening and she feels she's already behind, what do you want her to hear from you right now?
Even though your eggs are in your body your entire life, they are most sensitive to the world around them in the 60 days prior to ovulation. You can make a tangible improvement in your fertility and your health by starting to make simple changes right this moment.
Okay. Thank you so much for being with us today. Where can our audience find you?
I am on Instagram at Natalie Crawford MD, and then the book is The Fertility Formula, and you can get it anywhere that books are sold.
Okay. Amazing. Again, thank you so much for being here today and for joining us on Her Time, Her Health. I'm your host, Dr. Gila.
Thank you.